Hi everybody, thank you for joining me tonight. I'll just wait for a few people to roll in and then we'll get started in a little while. Hey guys, thank you for joining. Thank you for all of your questions. Hey everybody, thank you so much for joining. So basically, just to give you a quick little intro before we kind of get started, basically what we're going to be doing is every Wednesday, the first Wednesday of every month, we're going to be doing a fertility interview series at 7:30 p.m. With so many questions and interest that's been rolling in, we may have to do it a little bit more frequently than that. Maybe I'll do the off week and then we'll have a specialist coming every Wednesday, first Wednesday of every month. So we've got Dr. Kee Ong, we've got Dr. Alison G, we've got Dr. Manny Mangat, we've got Dr. Gavin Sachs that are all lined up, plus more. But tonight I'm really excited to say that we've got Dr. Lynne Burmeister. I'm just going to find her request. Here she is. Founder of Number One Fertility in Melbourne, which is an amazing woman-focused, couple-focused, but really sort of female-focused fertility centre in Melbourne and also in Geelong. Is that right, Dr. Lynne? Hi.
Yes, hi. Hi, everyone.
How are you?
For having me. Very good. How are you?
I'm good, thank you. Do you guys have all the rain there or no?
Actually, Melbourne's been all right today. So, no, we've been good.
Oh, that's good. Yeah. So, you guys been lucky. So sending all of our love to all of our Brisbane and Northern Rivers followers and friends. It's just, I went to university in Lismore. I've seen it flood before and it's just horrendous, isn't it?
Yeah, seeing those pictures, just awful. There's not a very nice time in the world at the moment with the floods and the war in Ukraine. We're just coming out of COVID. You know, it's been a pretty terrible time for everybody.
It's crazy, you know, and the thing we thought like 2020, 2021 wasn't great, you know, and then it's like, okay. Yeah. But yeah, so thank you everybody for joining us. So like, I'm so excited to have Dr. Lynne here to kick off our fertility series, our fertility interview series. I asked you guys for questions. So Dr. Lynne, you probably saw, asked if there was anything people wanted us to talk about. And like, I've just got literally almost 100 questions that have come in. So we don't have time for 100. But what I thought I'd do is try to kind of, I guess, you know, triage them out a little bit to make sure that they're ones that we're going to be, that you were going to be able to sort of answer. Like there's some stuff on like supplements and everything. So all of you who ask those questions, I'm probably going to jump on in another couple of weeks. I'll let you all know and answer those questions so that we're making the most of the time that we've got Dr. Lynne with us. What are you sort of seeing at the moment that, you know, I guess is like one of the biggest things that you're sort of finding in your practice and women and couples that are coming to you?
Well, I think they're a bit more aware now, Belinda. I think they're much more aware of, you know, their fertility, and they're actually coming to see me a bit earlier than what they used to. So sometimes you can see a couple till maybe 2 years of trying. But one of my last phone calls tonight, they'd only been trying for 6 months, but they just wanted to make sure everything was in order. So they were being proactive about their fertility, and I think that's very important. I actually think everyone trying to have a baby should have a pre-fertility assessment or a pre-pregnancy assessment. And that's really just making sure that everything is functioning properly. There's no point spending 6 months trying if you're not ovulating, or if there's no sperm, or you know, so little things like that, getting them checked out when we're going to start having family, and then just being reassured, hey, you've got great swimmers, hey, you're ovulating, you know,
relax, go away, come back in 6 months or a year if you need to.
And the other thing is the pre-genetic testing. So, and I think a lot of the children's hospitals are noticing that there is a decline in genetic diseases, and that's because people are taking up these pre-genetic testing. So, you know, getting yourself sorted, making sure you're getting screened for cystic fibrosis, which 1 in 25 of us carry. And then if you're carrying it and your partner's carrying it, 1 in 4 children have the risk of being born with cystic fibrosis. So you can get all that screened before you even start having a family. So I'm seeing people being a little bit more proactive. Still lots of education that needs to happen around that, and also maybe about the pre-pregnancy testing. You don't have to see a fertility specialist. Your GP can even do those tests and just make sure that you're ovulating. Make sure your AMH is good, because sometimes we even find that girls in their 30s have very low AMHs, and they're quite shocked to find that out. That AMH might be 5, when normally for a 30-year-old it should be around 15 to 20. So, you know, just little things like that your GP can actually just go through. You don't have to spend, you know, extra money seeing a fertility specialist. Go to a good GP, and your GP can run a lot of these tests.
Yeah, I definitely see that as well, people being more proactive. And it's hard, like I tend to find, like, you know, there's that balance between, I guess, you know, women who are quite anxious and or like slightly perfectionisty, aka maybe a little bit controlling, like a lot of us like to kind of be, you know, and sometimes that information stresses them out. But, you know, it's important information, because like you said, you know, we know that sperm rates are declining, you know, egg health, you know, not everybody has really good quality eggs, and they are things that you can get checked. It doesn't mean you're about to get shunted straight into IVF, which I think a lot of people think is going to happen at the beginning.
No, never. There's lots of things we can do before we do IVF. And in fact, probably only half the people I see actually do IVF.
Yeah, which is awesome. And what would you say in terms of, like, so they've done some like initial tests with the GP, when should they kind of then come and see a fertility specialist? Like, is it about after 6 months or 12 months, or what do you sort of think?
I think it depends on their age, but if you look at the statistics for getting pregnant, so in your first 6 months, it's 60%. And then in your second 6 months, it's only 25%.
Yeah.
So there is that big drop off in the second 6 months. And then 85% of people are pregnant by the end of that year. And then 15% are then diagnosed with infertility. So I think it depends on your age. If you're sort of over 35, then definitely see a fertility specialist at 6 months. But, you know, if you've got anything wrong with any of those tests, like say if your GP tells you your egg bank is very low, or there's something wrong with the sperm, then you need to see a fertility specialist straight away. So see if we can help you out. Yeah.
And I think the thing, and we'll dive into all your questions in a second, everybody, is one of the things that I seem to find is, like, people come from their GP saying, oh, your AMH is really low, you need to go straight to IVF. But, like, would you agree that, like, you know, AMH absolutely gives us an idea of kind of like time and egg reserve, but it's not a measure of fertility, right? Like, so you could have a low AMH and fall pregnant the first time, or have a great AMH and take, you know, a long time to kind of conceive. So would you say there's still, like, you should still be trying naturally and not lose hope with that? It's just more that you might seek intervention a bit sooner. Would you say that's correct?
Yeah, AMH is really just a reflection of how many eggs you have left. It's not necessarily your quality, and it doesn't lower your chance of getting pregnant. It possibly means that you might go, the average age of menopause is 52, but it might mean that you might go into menopause in your 40s rather than in your 50s. So, but it doesn't necessarily mean you're infertile, but it might hurry you along a little bit on your journey.
That's what I always say, like, don't decide, oh, stuff this, we're going to jump in a van and drive around Australia for a month and not try for a year and then come back. It's like, don't, if you're in that position to be able to try now, but also know it doesn't mean you're not going to fall pregnant, you know, naturally or with IVF, right? No.
And also there's things in your baseline test that we look at as well, like your vitamin D levels. So if your vitamin D is low, we know that affects your egg quality and sperm quality. So there's little things like that. Your GP can even fix up an iron deficiency. A lot of women suffer iron deficiency. I think it's like 1 in 6 women suffer iron deficiency. Get that fixed. That's going to help your fertility. Celiac disease, very, very common. Treating that will help you.
And so much undiagnosed celiac disease, right? Like, I'm you know, astounded. Even people who are asymptomatic, so these are all things that we're wanting to kind of have a look at.
Well, we do that on all our baseline tests before they come to see me. We do a celiac antibody, and again today I've spoken to someone with celiac antibodies having a gastroscopy on Friday. because they were really, really high. And she's actually been trying for over a year to get pregnant. So it's probably celiac disease.
Yeah. And that's the thing, isn't it? Like, you know, I would say I work with quite a few specialists, obviously, in terms of like patients, seeing lots of different specialists. There's sort of like you and a couple of others that I know, if they're coming from these specialists, they've done pretty much all the tests that I would want to sort of see as well. But there's a whole heap of people out there as well that maybe think they've done all the tests but haven't. So they come with what I affectionately call the "you're not dead" test. You know, like you don't have HIV and syphilis, and awesome, great news. But there's not there's not always been that investigative workup as to what doesn't happen, which, I mean, seems a little bit kind of crazy. I know testing's expensive for Medicare and all that kind of stuff. But yeah, Dr. Lynne's definitely one of the doctors that is going to look at everything, not just go, oh, you've been trying for 6 or 8 months, you're not pregnant, you should probably just do IVF.
No, we've got to correct things like, you know, thyroid, or even having thyroid antibodies might be causing you to have miscarriages or not to get pregnant, celiac disease, vitamin D levels, vitamin B12 levels, iron levels. So there's so many things that we might be able to correct that can help you get pregnant naturally. And we also know that even having your tubes flushed with the oil, I call it the magic oil, that increases your pregnancy rate to 40%. So why not start with that if your fertility doctor thinks that's a sensible approach? And you can just do that in an ultrasound department. You don't need to have surgery to do that. And wow, 43% of people get pregnant within 4 months of doing that test. So
that's crazy, isn't it?
Yeah.
So, and what's the stats for? So that's the Lipoidal flush, and I know that that's not done everywhere, so not everybody really has access to that. Would you just say like the normal tube flush is like what's the sort of percentage there? It's not
probably more around 20% improvement.
Oh, really? Yeah. So it's quite a big difference if you can.
It is worthwhile trying to find a place that will do the Lipoidal flush as well.
Yeah.
The Lipoidal's got poppy seed and iodine in it, and the thought behind it is the poppy seed works as an anti-inflammatory and the iodine works as an antiseptic, and it just washes and cleanse out the tube, so it gives them a spring clean, so to speak. And I just got off the phone from someone early. My first consult this morning was a patient with Fragile X who'd been struggling, and she was going to do IVF and then do embryo testing, but really didn't want to. She was only 28. And when you have Fragile X, you actually are running out of your eggs because it actually lowers your egg number. So she did the Lipoidal flush, and she's pregnant first month after trying that. So, and that's how year of trying. She will need to do a CBS though to make sure her baby's not affected by the Fragile X. But she's happier doing that than doing the full IVF and things.
IVF, she really testing and
she really couldn't afford to do that.
So that's good to know, because like a lot of you know, I've sort of, you know, when people see me, I often give them, I always give them a list of tests, a letter to their GP to get stuff done. And the amount of GPs that come back and say, I don't know what you're talking about with the Lipoidal flush, you know, so it is worth pushing. I know in Sydney, like you can do it at RPA, and there's another place on the North Shore, but it's not at everywhere. So it's not that easy to do.
You'd think that some of the women's ultrasound departments would be doing it. Maybe
I think there's a couple that do, but it's certainly not all of them. So I don't really know why, but so that's interesting, because I didn't realize the success rate went from like 20% to 43%. That's massive. So, you know, worth pushing for, guys. You do need to kind of advocate for yourselves in this world a little bit. So let's jump straight into some of the questions, because there's like way too many for us to kind of answer. But I'm going to throw them at you, Dr. Lynne. So would you say, this is an interesting one and topical. Thanks, Anna. I hope you haven't had COVID, Anna. But anyway, recently, how long should you wait for an FET after having COVID? So this is interesting. I know Janaea won't even let you back in for 7 weeks. I know IVF Australia won't let you back in for 4 weeks. Others just let you straight back in straight away. Do you know any of the reasoning behind that, or whether you should be waiting?
Well, no. Funny enough, another story today was someone actually got pregnant naturally, you know, when they were at home locked away with COVID together.
Oh, yeah, right. They obviously weren't too sick. They were just bored.
So she just phoned the clinic today and said she doesn't need her frozen embryo transfer next month because she's actually pregnant naturally. So
amazing.
There's no evidence that COVID does impact your chance of getting pregnant. So say if you caught COVID and you were day 1, you just have to follow the current guidelines that you have to isolate for 7 days, and then you're free to come into the clinic after that 7 days.
And do you know why some of the other clinics are weeks and weeks, or it's just, I don't know, nobody knows?
No, I think there's some rules in some hospitals as well that you can't have an operation for 3 months after COVID. So everyone's got different rules, and I don't really.
And it'll all change in a hot minute, right? I mean,
a bit like the stopping IVF in Victoria a few weeks ago, and then a week later we got started back up again. So there's so many rules and regulations, and a lot of it doesn't have any science backing. And a lot of the decisions don't really make any sense. So if you were, say, for example, in this situation, if you were using donor egg, donor sperm, so you've created kind of embryos, and these things are, every embryo is precious. And like obviously the cost and all that sort of stuff with that. Would you say wait a month, or just if you've cleared your 7 days, then? If you've cleared your 7 days and you feel perfectly well, then go for it. There's no reason. I mean, if you've got post-COVID symptoms, no. But if you're perfectly well, like a lot of people who get COVID don't even know they've got it. And that's why it spreads so easily. But if you're perfectly well, there's no reason to wait.
So if you were sick for a few days, you felt better, you've done your isolation, and the next day is day 10, you could go in for like your transfer on like 5 days post-ovulation or whatever, another week later.
Go in and get your monitoring done, egg collection, whatever, transfer done.
Great. Another question, how long after a miscarriage before trying again?
Well, there used to be the old wives' tale that you had to wait at least 3 months. That's actually not true, because you're actually more fertile after you've had a miscarriage, because your body now recognise your partner's antigens. And so it's actually started to implant, and the immune factors within the lining have changed now, and the lining's actually more receptive. So as soon as your HCG is back to, below 1, you should start again.
Okay, great. I had someone today that had to wait 3 months, and I was like, that's like, it's like the next month now. Like, that's old. I would say, would you say like 10 years ago? Like a long time that
No,
was...
some people are still recommending it.
This was someone in Queensland, but I was surprised. I hadn't heard that for a while. So this person, PCOS and not ovulating, all doses of letrozole have been unsuccessful. What would you say the next step would be to consider?
So how many cycles of letrozole?
It didn't say all doses of letrozole. I don't know. So maybe like she's obviously tried a few different doses.
So again, a tubal flush, if they haven't done that, and then maybe move on to FSH injections with monitoring, or maybe just move on to IVF. Because they might
how does the tubal flush help that if they're not ovulating? Do you mean like because they're not actually able to release the egg?
Well, because the letrozole hasn't worked, so why hasn't if she's been ovulating, why hasn't the letrozole worked? So maybe she has got blocked tubes.
Well, said not ovulating.
Oh, not ovulating. Okay, so then if she's not ovulating, then she could move on to FSH injection.
FSH.
So she needs to see a fertility specialist and get properly monitored and have FSH injections. Sometimes it can be very tricky though with polycystic ovaries because there's so many eggs, and sometimes you can grow too many and then you get cancelled, and then because of the risk of quadruplets or triplets, and so then you might go through all that hard work and get cancelled. So sometimes the easier solution is actually just to do IVF, because it gives you a much better chance of getting pregnant. But FSH injections would be the next step normally. The PCOS, it tends to be like, no response. Oh my gosh, yes, let's all respond. That's right.
Everyone comes to the party at once after not coming to the party. This is a really interesting one, and I've had another client that kind of had this as well. So extreme crippling and cramping and contractions for the 3 days post an embryo transfer. Is it adhesion related, or is there anything that's kind of going on? This has happened to this person for multiple cycles.
Yeah, it's probably the body just sort of trying to recognize that embryo, I would say. And it's also sometimes the progesterone sometimes causes a lot of cramping.
Yeah, so I was going to say, would it be the progesterone?
I think it's probably more the progesterone, and maybe switching the progesterone might be a good idea happening, and it's not working because maybe the uterus is cramping so much. So you could use subcutaneous progesterone. There's one called Protex. that is available, and it's not as painful as the injection.
It's not like the old oil one that had the big lumps under your skin.
That's right. So you could ask for your doctor to prescribe probiotics, and because the progesterone is not going near the uterus, it's probably not going to cause as much cramping.
Be so crampy.
So maybe you need to look at changing the progesterone administration.
Oh, that's great. Thank you. And when you said before, like your body recognizing it, would that be some sort of overimmune response potentially, or not really?
Hard to know for sure.
Yeah, probably you don't really feel that generally, do you?
Yeah. No.
Yeah. And someone else asked, do you recommend progesterone after ovulation or not until a heartbeat? So, I mean, I've only ever seen after ovulation, not until a heartbeat, but I'm guessing this is in a natural conception. It's a bit late by the time you get a heartbeat, right?
Yeah, by the time you've got a heartbeat, the progesterone's already, the placenta started to create the progesterone. You shouldn't really need it. In fact, some clinics stop progesterone once they see a heartbeat. So depending on what sort of cycle it is. So progesterone after ovulation is when we normally give it. With the person with
from a positive pregnancy test, would you say, if it was a natural conception?
If the person's had miscarriages, you might add that into to stop them from miscarrying, although there's not great evidence for it. But yeah, after ovulation, but not when you see the heartbeat. But if people have had a history of second trimester losses, you might add in progesterone at that point and continue that to their, their second trimester if they've had pregnancy losses in the second trimester. Yeah.
And that works as a bit of an immune suppressant too, right? The progesterone. So having that extra there helps to sort of settle down that immune response.
There is evidence that it is an immune suppressant. Yeah.
Yeah. Yeah. Do you prescribe anything different for IVF patients with elevated ANAs or anti-nuclear antibodies?
Yeah, so that's interesting because a lot of people have it, and it might be only 1 in 80 or 1 in 160, so it might be very low. But yes, I usually do prescribe something if they've had repeated IVF failure and we can't work out why. Like it might be a beautiful embryo, the lining's beautiful, but that little embryo is still not sticking. So we might prescribe things like prednisolone for that. And sometimes we might prescribe Plaquenil, which is another sort of anti-inflammatory type of medication to see if the embryo will implant with that. But a lot of these things that we try to get that embryo to implant have not been proven in large randomized controlled studies. They're just like anecdotal. Look, I gave that patient with that same problem Plaquenil, and now she's got a baby. Why don't we try that on?
Let's try it again. Yeah. And that's the thing, like there's doctors like yourself and a few others that are happy to kind of think outside, not think outside the square, but try these things that are maybe not fully kind of reproducible in studies. But, as I often say to patients, I mean, as you know, the whole IVF is not particularly, it mostly fails. So if it was any other medical procedure, it would probably be deemed unethical to have a 5, 10, 20, 30% success rate. So I always sort of feel like anything that we put into it that may sometimes help, as long as people know, that nothing's a guarantee. If they've had recurrent failures, it seems, I don't know, from a patient-centric point of view, which is you're awesome at, it is worth trying other things.
Well, it just seems illogical to keep doing the same thing over and over again and expect it to work. So I think that you've just got to try, and your patients want you to try other things. They don't want you to just keep doing the same thing. They're very motivated for you to try and find a reason. And sometimes we can't find a reason. It's very hard to explain to people, look, there's actually no reason why it's not implanting. But maybe if we try this Plaquenil that is used for people with lupus, for instance, and we know that lupus patients miscarry, maybe in 10, 20 years' time, we're going to find that Plaquenil is the treatment drug for people who have recurrent implantation failure. So, as long as you're not giving people medicine or anything that's going to hurt and cause them permanent injury, then I think it's fine to do.
Yeah. We don't want to use hope as a strategy.
No. Exactly. We don't want to cause any damage to our patients.
Of course. Yeah. And that's why, Dr. Lynne is awesome like that, because you sort of will do interstate patients where you can do the initial ones over the phone or telehealth, and then they come down just as required.
Yeah. We have a lot of people flying down for treatment. So we do telehealth appointments. They get their bloods and scans in wherever they live. wherever they live. COVID made it a bit difficult, and they fly down for either egg freezing or egg collection and transfer. We have a lot of interstate patients. I think a lot of the patients come to see me, one, because second opinion, but also our price point is much better than a lot of the other clinics around.
Yeah, for such a beautiful clinic that's not so kind of hospitalized, medicalized kind of feeling. And absolutely, like, you know, if you guys are looking at egg freezing or know anyone that it's looking at egg freezing, the price at Number One Fertility are like, out of control for that. Like, as in a good out of control.
And that's and we haven't skimped on science or anything. My passion has been to really come into the market at a different rate and really, you know, provide some competition, because there's never been competition before. And so it's almost like price fixing, I suppose, because everyone could just charge their prices they were charging. And my passion was really to drop those prices and provide really good competition and solid competition. And, you know, my lab is state of the art. You've got EmbryoScope Plus for every single embryo. You don't have to pay extra for that. I mean, that's just standard practice. Embryo glue is standard practice. Ultrasound gut transfer is standard practice. Everything is standard. We don't charge extra when we go and do your egg collection. So, you know, everything is just part of that package.
Part of the package. Yeah. You know what you're in for, basically. Yeah,
exactly.
Yeah, which is awesome. So no, you guys have to check out Dr. Lynne. Okay, so fluctuating FSH. This is interesting. So women who maybe aren't responding as well, maybe their FSH is a little bit higher. It's my understanding that if their day 2 FSH is kind of over sort of 15, they're probably not going to respond as well. I mean, I always like it under 10. Most clinics don't test it just as kind of like par for course. Would you say it's worth testing in women who are a little bit older, because it is a fluctuating level? You know, they might go, oh, it's 18 this month, let's not do IVF this month, and next month it might be 13 and it's worth doing. Would you say, what do you sort of think about that?
It depends on the patient and their history. So most patients, you don't have to check it, but say if you've had a patient that's had a surprising poor response, I would definitely check it on that, because obviously there's something going on behind the scenes. Behind the ovary scenes that is causing that ovary not to respond. So let's do a day 2 blood and see where your day 2 blood is.
And especially if you're over 42, 43, would you say, where you know, like
yes, exactly. And also if their AMH is really low, you might want to, just so they're not wasting a month taking medication for nothing.
And that's good. Chat, is it possible to improve chances of pregnancy after an ectopic pregnancy?
Yes. So, well, if you've had an ectopic pregnancy, hopefully the doctors, when they've taken the tube out, have looked at the other side. Or if you've been treated with methotrexate, then we don't know what the state of that tube is. So probably having a tubal flush would be a good idea after you've had an ectopic, to see if that tube with the ectopic in it, if it hasn't been taken out, is even open. And also flushing the other tube to see if it's open, because often ectopic pregnancies are caused because something was wrong with that tube. So you want to make sure the other tube's not blocked. So probably finding a clinic, you know, an ultrasound clinic that will even do the Lipoidal tubal flush and see if your other tube's open. That will improve your chance of getting pregnant. And then maybe seeing a doctor to go on some ovulation therapy, because remember, you're ovulating each month, but your ovaries actually don't talk to each other and go, hey, right ovary, I did it this last month. Hey, left ovary, you do it next month. They actually don't talk like that. So you could do 6 months in a row on your right ovary, and that might be where you've got the tube removed, and then the next 6 months might be the left ovary. It just doesn't take it in turns. So doing some ovulation therapy and having follicle tracking, that will also help you get pregnant naturally.
But the tube that's there though can float over to the other side and pick up the egg. That's correct?
Yeah, it can do that, but that's not very common. So
really? Okay.
Yeah, that's not very common.
My best friend, that happened. That's my godson or Baxter. And a few of my patients. But right. So that's quite uncommon, is it?
Yeah, that's not very common that happens.
Okay, So, well, let's not rely on that. Ovulation therapy sounds like that's a good idea.
When people have had an ectopic, it often takes them twice as long to get pregnant.
Yeah. This one's from one of my beautiful clients. Hey, Louisa. So she's just did an interview on SBS that I just watched today. I'm going to get back to you, Louisa. And so your thoughts on weight and BMI and the impact on fertility. So, you know, do you have a cutoff with BMI in terms of, you know, doing IVF in a polycystic patient who, you know, has been doing everything to kind of lose weight, but it's maybe they're quite sort of weight loss resistant potentially. What are you sort of like? Do you have a cutoff or what's?
It's very difficult because we do see that the pregnancy rates do start to decline, particularly if your body mass index is over 40. And then we've got to ask ourselves, is it actually safe to get that patient pregnant if her BMI is so high? And so it's safety for her during the pregnancy and for the baby as well. And there is a decline in pregnancy rates with people with elevated BMI. And yes, it is very hard to lose weight, but sometimes the weight is also causing your infertility. So even if you lose 5% of your body weight, that will improve your fertility substantially. And we do see that in embryo quality. We had a patient that was overweight and she couldn't even get to blastocyst stage. So I think her BMI was around 35. And we just went, okay, this is it. We can't even get your embryo blastocyst. You're going to see our GP in our clinic, and she's going to put you on this medicine called Saxenda, and you're going to spend some months doing the Saxenda. And she actually dropped a lot of weight. I think she dropped something like 20 kilos.
Wow.
And 6 beautiful blastocysts.
Yeah. Because I was looking, and I only just looked at this really briefly. She just sent me the link today, and I think it was on SBS, and it was saying somebody from the College of Obstetrics, somebody or others, was saying like, if BMI is over 35, then, you know, doing, you know, assisted reproductive treatments, you know, increases risk of like abnormalities and things like that as well. Is that like?
That's true. And so abnormalities in the baby, the babies are very hard to be monitored.
But obviously people who are overweight who fall pregnant naturally, I mean, that happens every day, and their BMI is over 35. So is it different with IVF and these poor people with PCOS that sort of maybe need IVF, or is it just because we're controlling it and so therefore the doctors are sort of not feeling comfortable with doing it?
It's been more studied in the IVF population, but definitely we do see a decline after BMI of 35 in pregnancy rate. And also birth outcomes as well. So congenital abnormalities and things. High risk of diabetes, preeclampsia, preterm labor, you know.
It's just hard though, isn't it? Because if you've been trying so hard and even using Ozempic and Saxenda and all those sorts of things, and weight loss is a little bit slow, you know, it's, do you not get a chance to have a try at all? Or, it's a difficult one.
It's hard if you're getting older. Say if you're 40 and you've got, you know, a large BMI, you don't really have time. So so that's a really hard one, you know.
It's really hard, and there's some doctors that do it and some doctors that don't, and you know, but I mean, you know, obviously we all want there to be the best chance, but not only, you know, people probably happy to have a low chance of success just to have a go, but if there is risk of, as you said, abnormalities and preterm birth and things, I mean, that's, you know, that's not ideal.
Ideally trying to get your body in tip-top shape before you have a baby. Having a baby is like not easy on the body, and if you're not in tip-top shape before you have a baby, it's going to be not only hard for you but also hard for the baby as well.
Okay, so these are all supplements questions, so I'm going to go back with those later. Liver pills, we asked about that one. Okay, sorry, I'm trying to get to the bottom of it. What's your view on the effectiveness of intralipids?
Again, lots of randomized, well, not many randomized controlled trials actually, and so not a great data. There's not great data about it. Again, though, I have had some success with it. I had a lady that had 7 miscarriages, and she wanted to do intralipid as per, you know, one of these studies she'd read, which was, you know, 5 days before the transfer, and then every 2 weeks when she was pregnant, right up until her 3rd trimester, and she had a baby after 7 miscarriages. So if you ask her what's her belief in it, she'd say yes. But again, you know, if everything else hasn't worked, and you want to try it, then we'll
no
try
harm
it.
done.
Yeah, there's no harm done as long as you're not allergic to any of the substances in it. Yeah.
Because you know, I sort of like, I think oh gosh, what was his name? A doctor in the States. He passed a couple of years ago. Can't remember. He did lots of the immune stuff. But, you know, he was sort of, I think, did some research on using high-dose fish oils versus intralipids. I think he was one of the first ones to do intralipids, but then kind of reversed it out, going, actually, we can get that from good doses of fish oil. But, you know, who knows? But, again, you know, we don't get to have, like you said, that patient, we don't get to have her 7th or 8th transfer without it to see what would have happened. You know, we just want to give these women and couples the best chance.
Yeah, and if you're not hurting anyone by giving it, and they want to try it because nothing else has worked, then why not?
Yeah, absolutely. So what's your dose on the ERA, EMA and ALICE tests?
Yeah, so for people who don't know what that is, ERA is a receptivity test, and that tells us when we're putting the embryo in, whether it's the correct day or not. And from our genomics, they say that in their studies, they think that we're putting the embryo in on the incorrect day in 30% of the time for those patients with a recurrent failed implantation. So what you have to do for that test, and a lot of people get it wrong, you have to basically do your frozen embryo transfer without putting the embryo in. So exactly how your doctor's going to do your frozen embryo transfer, that's what you've got to do. So you've got to be set up exactly the same.
Like sort of a fake cycle.
Yeah, like a fake cycle, but it can't be in an egg collection cycle. It has to be in a frozen cycle, because I've seen some results come through in an egg collection cycle. So that's actually, that person's wasted their money doing that. So it has to be, yes, it's very expensive. And then the EMA and ALICE is looking at the bacteria and the lactobacilli in the lining. And I think that's probably worthwhile doing as well. And there's surprising a lot of results that do come back with overgrowth of bacteria and not enough lactobacilli. So that's why I tell everyone when I consult with them on their first appointment, take a good probiotic, because so many people on that test come back with low levels of lactobacilli. So there's sometimes we'll pick up abnormal bacteria in the lining, and then we give a course of antibiotics. But then we've got to repeat the test and make sure that bacteria is gone.
Okay.
So then we spend more money doing that. But the receptivity test, I'm not 100% sold on it yet, because we've followed it and done exactly what it's told us to do, and still the embryo hasn't implanted. So and there's a lot of,
it's not the only thing going on, but maybe it's a picture to look at some point. Yeah.
So I think if you've had 3 failed transfers, I would speak to your doctor about potentially considering that test. It is quite a pricey test, and it's still being debated. When I go to conferences, people still debate about whether it does hold up scientifically, because people have been able to reproduce that 30%.
Yeah. And with the EMA and ALICE, I mean, the microbiome stuff, you know, if you're looking for a probiotic, you need one with high levels of different strains of lactobacilli. So, you know, it's not just any probiotic which have a lot of like bifidobacteria. You're wanting to be getting those high strain lactobacilli. And it's not the same test, but, you know, I've been doing quite a lot of the vaginal microbiome tests at the moment, which is not, you know, it's not exactly the same, but it's, you know, it's in the region, you know, and it's really interesting seeing different overgrowths and, you know, what we're needing to kind of be treating, different bacterias and different good and bad bacterias that kind of need to be there. So I think it's really interesting, all that microbiome stuff, because, you know, what they're saying now is it's almost like an organ in and of itself, you know, vaginal microbiome, gut, skin, everything. So I think there's probably going to be a lot of, probably a lot more research kind of coming in on that.
Yeah.
You know,
and
soon.
What probiotic do you recommend? Because
look, the Spectrum Pro 450 is a good one. And or even the, I mean, these are practitioner only ones, but and or the Orthoplex Multigen, they're quite high levels of lactobacilli. And there's another Spectrum one called Pro 8, which is super expensive. Somebody went onto my online store and tried to buy 8 of them, and I was like, oh, that's a lot. And then I realized that I was selling it for wholesale and not, I thought it was really expensive anyway. And then I put it up to recommended retail. She didn't want 6 anymore. I was like, why are you getting 6? She's like, oh, yours is like the cheapest by far. And I was like, uh-oh. I was trying to do just under recommended retail, but this was like $60 under recommended retail. So that one, you know, that one's the one that people tend to use when they come back with the embryonalus kind of being out, because when they give you those strains and things, like, we don't have the probiotics that they tell you to get in Australia.
Well, they tell you to get a vaginal one, so, but no one makes a vaginal one. I think JS Health makes a vaginal one, and that's the only one.
Same, you know, like I think Bioceuticals used to do one, and they used to charge like heaps just for 5, you know, probably the same that you could buy 30 for. Like, I get patients just up the hoo-ha overnight, and you can just use the same one. So you might get a little bit of discharge just because the cellulose, you know, which is looks like plastic, it's not plastic, little casing, you know, sort of comes out. But I mean, it just takes a little bit longer to dissolve because it's body temperature. It's not when you put it in your stomach, it's acid and it goes. But yeah, so I just use those.
Yeah. I've just had a patient who have some irritation, but that's a bit, you know, that's all.
Yeah, most people don't. And if they do, then we can either use the powder or you can open a capsule, and you can put it into like a little bit of coconut oil on the end of a tampon and put it up. Leave that in for a couple of hours, and then you like obviously remove the tampon, and most of it's in the vagina, and that's a really low irritant kind of way of doing it. And if you do the capsule, then I mean, there's a little bit of is it magnesium stearate, I think, in the spectrum as the excipient. So that's the bit that makes it not all go clunky together. 99.9999% of people are totally fine with it, but if you're super sensitive to anything, and you use the capsule, there's nothing else in there. So that coconut oil does the trick really nicely, and is way cheaper than, I mean, it's not cheap, but like, it's cheaper than when they market the vaginal ones, which are not that different.
No. And I think it's probably important that some people, if they're trying to get pregnant, just take it every day anyway. Like,
totally. Yeah. And also too, that's when we kind of, you know, and we'll do this in a couple of weeks, everybody, like really kind of going into your diet, because, you know, we can make good bacteria. You know, we can make the right environment for that. You know, it's like a forest, you know, you can plant trees, you know, but if you've got weeds there, you know, like you've got to kind of like sort that out as well. But, you know, eating well, low sugar and everything, you know, lots of vegetables, lots of fiber makes a massive difference. Okay, so thank you. That's all the tests, which is great. 6 chances of a successful pregnancy with Hashimoto's disease.
Yeah, well, I think if you've got your Hashimoto's disease controlled, then it should be just the same. There is a high risk of miscarriage, but if you're on your thyroxine and you've got that controlled, and your thyroid's functioning normally, then I think it should be fine. It just needs to be controlled properly. So just make sure you get that checked.
And you often need to have your thyroxine or L-troxin adjusted as soon as you fall pregnant. You usually need a bit more, right?
Exactly. As soon as you fall pregnant, you will need to get your thyroid checked again, because you'll actually need more thyroxine usually. But once it's treated and corrected, it should be the same. Yeah, there is a slightly increased risk of miscarriage. And that's, again, with some of my patients who have Hashimoto's that are on IVF and they have high thyroid antibodies. I might suggest that they might take some either prednisone or the Plaquenil.
Immune suppressants.
Immune suppressor, the risk of the miscarriage because of the antibodies.
Yeah. And I always like that TSH under 2. And I mean, if you're on thyroxine or L-troxin, it really should be able to be about like 1.5, right? But I think, you know, don't just, I mean, like, I want to say don't trust your GP, always trust your GP. But, you know, I have people come and, you know, their TSH is like, you know, 2.8 going into a pregnancy. This girl I'm thinking of, 3 losses, they're still saying her thyroid's fine. I finally got her into a doctor that gave her thyroxine, and she's now 8 weeks pregnant. Like, I was like, it was going up, you know, it was baseline was 2.8, and it always goes up in terms of, you know,
and it could be different. It could go from 2.8 to 5.4 as soon as she's pregnant.
Yeah, really quickly. So, you know, it is important that, you know, if there is a little bit of kind of like thyroid stuff, you know, get a second opinion if you're not sure, because different doctors have different interests, and, you know, everybody can't be across everything. Particularly I always feel for GPs, right? Like, they just did someone's heart medication, someone's stitches, someone's diabetes medication, you know, like it's, you know,
like if it's in range, if they see it's in range, they'll just go, okay, it's in range, you're fine.
Yeah, but there's that subclinical range that's worth looking at. Okay, this poor lady here, IVF miscarriage. She's had 2 failed transfers with PGD embryos. Should she be doing any other tests?
Yeah, so 2 failed transfers. So if you've got a PGTA embryo, your chance of getting pregnant should be around 55%, and your chance of having a baby should be 45%. So that means she's had 2. She should be close to 100% having a pregnancy. So yes, definitely look at other things, like if you haven't had a hysteroscopy, maybe you need a hysteroscopy. If you haven't had a laparoscopy, maybe you need a laparoscopy to make sure you don't have hydrosalpinges that can affect implantation. Get your blood clotting, your thrombophilia checked, get your autoimmune screen checked, and then ask your doctor to consider doing the Youre, Emma and Alice test as well. And make sure just basic things like vitamin D, thyroid antibodies, celiac has been signed off as well. Just make sure
natural killer cells, all that immune stuff.
Yep, natural killer cells, and make sure all that stuff has been tested to see why those embryos haven't implanted, and get someone to look inside your uterus, I would say, because maybe there's something wrong in there that's just stopping them from implanting. So and even there's studies that show that that I call it the magic oil now, the Lipoidal oil. The studies show that with failed IVF implantation, that actually might help improve embryo implantation.
Yeah.
So having
just that antiseptic, anti-inflammatory through the tube, through the uterus.
Yep. Yeah. So having that flush through at the time of your hysteroscopy, laparoscopy, ask for that to happen as well. So lots of things that you can do if you've failed transfer. Yeah.
Because I've had quite a few patients, I mean, not heaps, but enough, you know, where they've had a hysteroscopy and they've just got endometriotis, so not osis, but just inflammation of the lining of the uterus, some antibiotics, boom, you know, they might have done 3 or 4 transfers, boom, next month they're pregnant naturally. And you're like, I mean, you don't, obviously you're not going to go straight to a hysteroscopy, like, you know, maybe before you even started, but like, you know, you're like, wow, like no symptoms, no idea, so simple, the fix.
And such a simple thing, and then they've done all this IVF and wasted a lot of time and heartache.
And that's what's important to, if you've had a few, to be looking at somebody who, you know, get a second opinion if somebody's just doing the same thing again. It might be that you just do need a few more cycles, but you know, you don't want to find out later, oh, you should have just taken some antibiotics or done this or that, and
and that's why we do. That's why we do an endometrial biopsy before anyone starts, because 1, we want to make sure that when we have the embryo, we can get it in, because some girls have cervical stenosis. 2, we want to check the lining, and then 3, we just do natural killer cells on everyone, even though, again, that's a whole nother can of worms. A lot of people don't believe in it, but and then 4, the scratch effect, but there are studies that show that the scratch doesn't work. But I've also had a lot of patients where
if you're in there, it doesn't hurt to do it, right?
Well, I've had people swear by the fact that they believe that the scratch has worked. You know, people that have actually become pregnant naturally after having a scratch. So there's a few reasons.
You're one of the only clinics, I would say probably only clinic, that does all that as part of a course before people go into IVF.
Yeah, I've picked so many things up, like hyperplasia, which is pre-cancer. And people have been on IVF and they've come to see me. They've never had their lining checked, and they've got pre-cancer changes inside the uterine lining. I picked up endometrial cancer, and that poor girl had to actually have a hysterectomy because it was too far gone. Endometritis, as you said, just a course of antibiotics, and bingo, you're pregnant naturally. So I think it is actually an important test to do before someone starts. Yeah.
And even cervical stenosis, like you mentioned, that's guys, when the cervix is really tight, which makes it hard to put a speculum to put the embryo back in or whatever. But like that can also be a reason why maybe somebody's not conceiving naturally, right? So, you know, if the cervix is really tightly shut. So I guess going into IVF, it might also kind of give you, well, this is maybe why you need to kind of be here, because maybe that's been more difficult, would you say?
Well, with cervical stenosis, if your period's coming out, then it should be fine, because the sperm but it certainly makes the transfer easier, hard. So when you've got an embryo transfer that's difficult, that already lowers your chance of getting pregnant. So if your doctor's struggling to get your embryo in, that's not a good sign. If there's any bleeding after your embryo transfer, that's not a good sign. So we like to see our catheters, and we actually noted in our notes whether the catheter came out clean. We don't like our catheters coming out with blood all over them. That means we've struggled to get through the cervix canal. So the transfer should be really, really smooth. and should really take the doctor 2 seconds to get the embryo back in. Shouldn't be any fiddling, asking for tenaculums. You know, it should be a really smooth day. And that's why we like to have our patients prepared before their transfer day to make sure if they do have cervical stenosis, well, you need to have a hysteroscopy and dilatation of your cervix before you go.
You're not wasting an embryo by bumping it around.
Yep, exactly.
Yeah. Okay. Oh, that's such good kind of information. So any recommendations for recovery after laparoscopy and endometriosis removal?
I think just take the time you need. So usually it depends how aggressive the endometriosis has been and what the doctor's done. But, you know, just take that time you need. And usually I tell patients when I do a laparoscopy, just take that rest of the week off. I do my lists on Monday or Tuesday. I say just take the rest of the week off. So just take off the time that you need, you know, and just rest.
Everyone's rushing back, aren't they?
Yeah. When you feel back to normal, go back to normal activity. Yeah.
I think the working from home, I've had quite a few people have a laparoscopy in the last, you know, couple of years, and they're like, oh, have a couple of days off. At least you can be doing a little bit of stuff from home if you do have that really kind of like pressured job. You're not having to go in there. But I mean, obviously the more rest you can have after any of these procedures, the better.
Yeah.
Catherine has found out she's got a cyst on her ovaries. Should she be trying not to fall pregnant?
Depends what sort of cyst it is. In the old days, I say, and that's not that long ago, maybe even 5 years ago, we used to all rush in and remove cysts, but most cysts will go away naturally. So once you want to make sure it's not a cancer to start with, so please get a good ultrasound, make sure it's not cancerous. But if it's a benign cyst, often it will just go away. If it's a dermoid cyst and it's not very big, you can leave it. And even if it's an endometrioma cyst and it's not very big, you can leave it as well. Because there's now studies that show that we probably in the past went in and took out endometriomas too often, and then we ruined people's egg banks by doing that. Because they grow back, they're like pimples. They just keep popping back up. And so then you again take the endometrioma out again, and then that poor person's lost more eggs by taking that out. So now I tend to probably try and leave the endometriomas and do, unless they're really, really super big, but try and do the IVF around the endometrioma is probably a better idea.
Okay, that's interesting. And then probably the last question is fresh versus frozen transfer.
Yes, well, we do see from many studies that there is increased pregnancy rates with frozen embryo transfers, and we think that's because the lining's not overstimulated. And in some patients, it can't be in every patient because our pregnancy rates are still good in our fresh embryo transfers, and they're still good in our frozens. But in some patients, probably your lining hurries up when you're on all those stimulation drugs. And there have been studies where they've taken biopsies of people's lining on the day of their egg collection, and they found that their lining's almost premenstrual. And then you have those patients where you put the embryo in and then they ring the clinic 5 days after their embryo transfer and they've got their period already. So definitely those patients need to have a freeze-all, but not in everyone. So it would depend on things leading up to the egg collection. So if you've got an elevated progesterone pre-egg collection, then you definitely should not be having a fresh transfer. Your embryo should be frozen. So I know some clinics don't even measure blood, like they don't even do estrogens and progesterones before that people take their trigger. They just base it on follicles. So everyone that comes into our clinic gets an estrogen and progesterone and an LH check. So we look for all of those things, and we'll tell our patients whether it's safe for them to have a fresh transfer. Frozen transfers may work better because their lining's not being overstimulated with all the drugs, and that's the theory behind that. Maybe because of the progesterone rise before egg collection. So frozen embryos, yes, are a good choice. And also you can test, when you do a frozen embryo, you can actually test your embryo if you are over 35. And we do know that tested embryos do have a higher chance of getting you pregnant and a higher chance of a live birth. So I often suggest that when you turn 35 and over, because you'll get pregnant more quickly and you'll have less chance of miscarrying as well.
Yeah. And you also know that if you're lucky enough to have, more embryos, that, I would say to people, like, what's in the bank for later if this one is successful is genetically possible, rather than having 4 that, you think, oh gosh, there's heaps, you know, maybe there's only one that's genetically normal, at least you know, you know, you might want to put that in sooner or try naturally or whatever after that
so
kind of baby.
Exactly. So it's not a mystery dip, you know, like it takes away that mystery dip, basically.
Yeah.
Because like even when you're 31, we had a 31-year-old come through the clinic and she hadn't had her embryos tested before, but we tested them this time. And 75% of her embryos she'd made were abnormal. So it's like, probably we were putting a lot of abnormal embryos in. So so
and then you start exploring all these things, immune and this and that, and taking time and whatever, and actually, you know, they might have just had a high proportion of abnormal embryos,
even though they're younger.
Oh, that's awesome. Thank you so much for joining us. I know we're about to run out of time for the hour. We probably, you know, there's questions to kind of go all night. So I'm definitely going to be inviting you back on. For everyone that's watching, for today until tomorrow night, until next week, I'm offering 50% off my online courses. So you can jump into my bio and do the 14-day IVF support program or the 5 weeks to fertility. And the code is Fertility Series 1 with just the number 1. I'll pop that in the comments. So Fertility Series number 1, no spaces. You can put that in the coupon code for 50% off for the next week, and that'll give you recipes, meal plans, you know, meditations, all the research, all the science, and all the food and lifestyle and everything that can go alongside. Go and follow Dr. Lynne. She has heaps of these Instagram lives with so many different specialists and doctors and nurses, and she really is a kind of a one-stop shop for fertility, which is fantastic. So thank you so much, and I look forward to having you again very soon.
Oh, thanks for having me, Belinda. And if you haven't read Belinda's book, I'm going to plug you.
Get a little plug there. Thank you.
We have them in the clinic for sale. If you haven't read this, it's a great book to read. And remember, when we're treating you, we want little Olympic athletes. We want Olympic eggs and sperm, because then we can make you a little Olympic embryo. And if we make a little Olympic embryo, we've got a higher chance of getting you pregnant.
Yeah, and feeling good in the pregnancy. Like, so much of it's about getting pregnant, but then it's like getting the 2 lines, but then it's sort of like, oh, now you're going to be pregnant. So we want to make sure that, you know, you're in the best possible health, because the fertility journey is taxing.
Yes, definitely.
Yeah.
So thank you so much.
Thank you so much for spending your time and your evening. I hope everybody's staying on the east coast of Australia, at least, is staying safe and dry and warm and all those things. And we'll speak to you soon. Thank you so much for your time.
Thank you for inviting me, and thanks for joining, everyone.
Thank you, everybody. Thanks for your questions. See you guys.
Bye.
Thanks. Bye.